So that's the upside. The downside is then she asked me to talk about parenteral nutrition. And I said, that's like a Herculean task. And she said, oh, don't worry about it. You know, there's this great slide set that NASPGHAN put together on parenteral nutrition. You could just use that. So I thought, well, that's a good idea. So I went to the slides, through the 16,000 slides, and picked up the best 500, and that's what we're going to go through today. But then the other problem was the fact that it's not like you guys have not used parenteral nutrition before. How do you advance this thing like that? That one? I knew that. So it's like something like this. Study shows frequent sex enhances pregnancy chances. I mean, it's not like you guys haven't used parenteral nutrition before. So what I'm going to try to do is maybe cover some things that maybe you didn't know, and if you did know it, that's great. Again, the slides on the flash drive, I guess, are the official ones. I edited mine because I always get bored. Okay, so I thought it'd be nice just to talk a little bit about the history of parenteral nutrition. Actually, parenteral nutrition started in the 1600s when people tried to shoot each other up with wine and things like that, and that didn't go very well. So it was really not until the 30s that, whoops, so I don't know how to work this either. Until the 30s where people showed you get positive nitrogen balance with infusion of protein hydrolysates in children. In the 40s, people used glucose, casein is a protein source, and olive oil. And for the first time, we're able to show that you could give that to somebody and not kill them. In the 60s, lipid emulsion was invented, and in fact, it's the same lipid emulsion we use today, which is kind of a sobering thought. And then it was really from the University of Pennsylvania in the late 60s, 1966, that they showed in dogs that you could actually get these puppies to grow on a parenteral nutrition formula, and then it was just 2 years later that the first clinical report of a child actually thriving on parenteral nutrition was reported. And unfortunately, parenteral nutrition has not changed that much since then. So let's talk a little bit about the indications and routes of parenteral nutrition. Again, a lot of this is pretty obvious to most of you. Of course, the golden rule is use enteral nutrition whenever possible. We always say that, but when I walk around the hospital and I see patients, I realize, as we all do many times, that that's not really what's being done. Parenteral nutrition really should only be used when you can't meet the requirements enterally. That doesn't mean that you can't use a combination of enteral and parenteral. That can be very helpful. The guidelines in terms of when to start using it, these are really pulled out of the air, and there's no hard data on this. For infants, it's felt to be up to 3 days, and then you should start thinking about using it. Children and adults, somewhere between 4 and 5 days. In adults, somewhere between 7 and 10 days. As you saw before, if you just totally starve an adult, like you and me, we started starving, it would take us about a month or so to die. So obviously, there's a lot of fudge factor in these, and this would also depend on the baseline nutritional status of the patient as well. This seems like a little bit complicated chart, but I think it's actually a good one that was from the Aspen American Society of Parenteral and Enteral Nutrition Guidelines. And I think basically what it shows is you assess the patient either through some of the anthropometrics we talked about, that you heard Maria talk about, or just a global assessment, and then you decide whether or not this is a patient that can have some enteral nutrition, and if so, what type. Are they going to need long-term therapy, like through a tube, or short-term therapy through like a nasogastric tube? And then you assess where the patient is at, and then you decide whether they're going to have a standard formula or there's something wrong with their gut and they might need a special formula. And the same thing is true with parenteral nutrition. So somebody just needs peripheral because they're only going to be on it for a fairly short time. We'll talk about that a little bit. Or long-term, in which case they need central TPN. Importantly, though, again, I made this point a minute ago, and I want to make it again because I think it's not used enough. These two things are not mutually exclusive. Many patients may not be able to take everything enterally, either by mouth or through a tube. And in that case, parenteral nutrition, peripherally, might be a benefit. So other indications, again, these things are self-evident. You're familiar with these all the time, so I don't think we really need to go through these specifically. I think inflammatory bowel disease, I guess you guys talked about that last night. So if you sort of have covered this, then I'm already sorry. But there actually were data maybe about 20 years ago or so that showed you actually could put patients with Crohn's disease at least into remission by putting them on parenteral nutrition. and keeping the NPO. The downside is once you started feeding them again, then they got sick again. But it can be helpful for patients who have fistulas, particularly perianal disease, in terms of when you're trying to deal with that. And luckily, we rarely see short bowel patients, and at least pediatrics who have from Crohn's disease from their surgeries. Short bowel is something that's much more familiar to us. And again, we really need to think hard about everything that we can do to feed a short bowel patient enterally before we stick them on TPN, and use as little parenteral nutrition as we possibly can. Obviously, starting trophic feeds is important. We'll talk later about cycling TPN and how important that can be. And then short bowel kids oftentimes suffer at our hands because we don't give them enough calories, enough protein for having them grow properly. Sometimes that's because they're oftentimes getting sick, but that's something we really need to pay attention to. The route of administration, of course, is either peripheral or central. By definition, central means that the tip is positioned in the superior or inferior vena cava. And in fact, it's not really advisable to put it into the right atrium because it's more likely to cause complications such as arrhythmias. Most places, well, I won't say most places, how many places do you guys use PICC lines? Peripherally inserted, yeah. So that seems to be sort of the trend nowadays, where when kids need parenteral nutrition, they wind up getting PICCs. And it's probably not a bad thing. They work really quite well. And kids who need long-term therapy, then they should have tunneled catheters because these are associated with less infection and last longer. I think peripheral TPN is underutilized in many patients because we just don't think about it. And oftentimes we'll jump to the PICC. And although most of us are not familiar with it, a lot of our renal comrades and malnourished patients can actually put parenteral nutrition solutions into dialysis solutions and give parenteral nutrition through dialysis. That's well described. So the general guidelines, again, there's no magic to this, and a lot of times, as you well know, clinically it's very difficult to make that assessment. But usually we think about using peripheral TPN, the patient's going to be on for less than 2 weeks or so, if they have no fluid restriction. And that's important because you can give a patient all the nutrient they require via peripheral TPN. But yet I rarely see that done. For some reason, it's like you give patient maintenance calories through their peripheral IV with parenteral nutrition. And there's really not a whole lot of point in that. If you're going to give them parenteral nutrition peripherally, then give them enough so that they actually get adequate calories. But to do that, you have to give them a fair amount of fluid. The limiting step, of course, in giving parenteral nutrition peripherally is the high osmolality. And a lot of that osmolality comes from the dextrose. So the maximum dextrose we usually recommend is about 10 to 12.5%. For central TPN, of course, that's for longer term. The other advantage there is that you can really use much more concentrated solutions. So if the patient's fluid restricted, that's certainly an advantage. And the components, well, it should contain all the things you'd get in a normal, healthy diet. And this is a typical redneck seafood diet from Texas. All right, so this was touched on before, and I think it's really important to think about what's in TPN is really two major components, and that's energy and protein. The protein comes in the form of amino acids, and the energy comes in the forms of dextrose, glucose, and fat, meaning lipid. And these two things really should be thought of separately, because as you heard very nicely before, you die of protein malnutrition. So that's the thing that you really should concentrate on, and shouldn't think of protein as an energy source. And so when you calculate requirements, you should calculate energy requirements and protein requirements separately. And of course, you have all the other things that you need to survive. These are the two guidelines, one from the American Academy of Pediatrics and the American Society for Parenteral Nutrition, ASPEN, in terms of what the intake should be for protein, calories, and so forth. And again, this is in your syllabus. The only thing I want to point out is that if you look at any of these things, you see pretty big ranges. So protein intake is anywhere from 1 gram per kilo to 2.5 grams per kilo. That's 2.5 times difference. And the point there is what Maria alluded to, is that you really need to look at the patient and decide what the appropriate intake is. If you have a patient who for some reason, let's say, has a bowel obstruction, but they're actually really well nourished, and they don't have any other sources of protein loss, they would certainly fall on the lower end. If you had a patient who was malnourished to begin with, who had low protein stores, they would run on the high side. So again, there's nobody that can stand there and tell you what to do. You really have to use your clinical judgment and recognize that everybody's different. And even if you took all of us and measured all our metabolic rates, as we heard about earlier, and measured all our protein requirements, you'd still see that there was a range. So you can't pick a number and sit on that number and say this is right for that patient. Okay. So this points out the importance of the difference between amino acids, that is protein, and carbohydrates, or energy, or fat for that matter, in terms of enhancing protein retention. On the y-axis, we have protein retention, and on the x-axis is non-protein energy intake. So what I want to show you is that if you double the energy intake, let's say from 40 to 80 calories per kilogram per day, and you keep the protein intake the same, or the amino acid intake the same, this is the kind of increase in protein retention you'll see. Now, if you hold the energy intake the same, but you double the amino acid intake or the protein intake from 1 to 2 grams, you see that you get a much bigger boost in protein retention. So if you had the choice of a patient that's fluid restricted and you had to make a decision, am I going to give them adequate calories or more protein or more amino acids, the choice is always going to be amino acids. So dextrose or glucose is the major source of non-protein calories. So glucose and dextrose are the same thing. It typically provides 40 to 55% of the caloric intake. Again, there's no magic to that. That basically matches what we should be seeing in the diet. One important point about glucose in parenteral nutrition is that normally we think of glucose providing 4 calories per gram, but because it's the monohydrate form in TPN, it actually only provides 3.4 calories per gram. As we heard about in terms of refeeding children who are malnourished, the same way we have to be careful about increasing the rate of glucose infusion so that we don't prevent either hyperglycemia or an osmotic diuresis. And as mentioned earlier, since glucose is the primary driver of osmolality, particularly in peripheral TPN, we have to be careful of the risk for phlebitis. This, I think, addresses somebody's earlier question about glucose oxidation. So as you infuse glucose, there's only so much glucose that you can oxidize. And the rest of that glucose then turns into fat or is excreted as CO2. So that's not necessarily a bad thing, because if you have somebody who's malnourished, obviously one of the things they are going to be malnourished in are their fat stores. On the other hand, you can also make somebody fat by obviously giving them too much glucose. Or in somebody who has pulmonary compromise, you can also potentially drive them into respiratory failure or distress, because glucose gets oxidized into CO2, of course. But when it gets turned into fat, the amount of CO2 that's produced is much greater than the amount of oxygen that's consumed. And so CO2 production is increased quite a bit. We don't see that very often, but it is a theoretical possibility, and does happen. In terms of protein, as I mentioned earlier, protein should not be thought of as an energy source. It provides structure and muscle, provides function in terms of enzymes, transport proteins, and acts as a nitrogen donor to other compounds. So don't think of it when you're calculating energy needs. As we saw in those slide earlier, protein requirements really vary by age and disease state. You heard about the essential amino acids, I won't go over those, or semi-essential amino acids, just to say that you can also overdo it. You give somebody too much protein and make them azotemic. So let's turn to fats. It's too early in the morning for this? Is that the one? Okay. So fats are a great source of calories because they're a very concentrated source of calories. In children, we only use a 20% emulsion. The reason for that is because the 10% emulsion that, I'm not even sure how many people use that anymore. You guys, no, hardly anybody, yeah, so don't worry about it. Drives triglycerides up higher. As I mentioned, the lipid solution we're using now is the same one that was invented in 1961. And it consists primarily of either soybean oil or safflower oil, and emulsified by egg yolk. So fat and water don't mix, and that's why you need the egg yolk in there. And actually the egg yolk brings it up to make it isotonic. You need a minimum of about 1 to 2% of calories, of total calories, from a combination of the two essential amino acids, two essential fatty acids, linoleic and linolenic, to meet essential fatty acid requirements. And usually you achieve that with about 0.5 gram to 1 gram per kilogram per day of the fat emulsions. You may have heard the triene-tetraene ratio. We don't usually measure that in practice many times, but it's a measure of essential fatty acid status. And what it means is that the essential fatty acids are tetraenes. And so if you look at the ratio of the other fats to the essential fats, that ratio should be generally less than 2. Another fallacy sometimes is that you should infuse the fats over 12 hours or 16 hours and then give some time then stop the infusion, then give some time for the fats to clear. And that's actually not true. You should infuse the fats over as prolonged a period of time as you can to maximize their tolerance, and then monitor serum triglycerides to assess their tolerance. Another sort of a myth is that fats are cleared in the liver, and IV fats are not cleared in the liver. This is a study from a number of years back in Sweden when they could do those kind of things, and they did do those kind of things. They infused these people with radioactive intralipid, and they looked to see where the fat was metabolized. And if you look, the majority of the fat metabolism occurs actually in skeletal muscle, followed by the splanchnic circulation, and then myocardium and subcutaneous tissue, with essentially none of it in the liver. And the reason for that is because fat is broken down by lipoprotein lipase, which is in capillaries. And of course, the biggest massive capillaries you're going to have are in areas like skeletal muscle, splanchnic circulation, in the heart. If we look at a comparison of lipid emulsions, essentially, as I said, the one that we have here approved by the FDA in the United States is the soy emulsion or safflower emulsion. That's designed to provide energy, and mostly in the form of the essential fatty acids. Now, how many of you used fish oil or are familiar with fish oil? Just to get an idea. Okay, so fish oil has sort of come up, and we'll talk a little bit more about this in a few more slides, in its relationship to using for cholestasis or children with cholestasis. But as you see, fish oil contains a lot less of the essential fatty acids. But under normal circumstances, if you give a gram or so per kilo per day of fish oil, for most patients, that provides adequate amounts of essential fatty acids. Then there's the so-called SMOF solution, which is available in Europe, not here, and nobody to my knowledge, I don't know, Mark, if anybody knows when, if ever, we're going to see a different lipid emulsion in the United States. Everybody shakes their head because nobody knows. But just to let you know, because you might read about this, and sometimes you see articles in JPGN about SMOF from our European colleagues. It contains soybean oil, medium-chain triglycerides, olive oil, and fish oil. So it's supposed to be the best of all worlds. There's not a lot of data on this in kids, but it does appear to be safe. There are some theoretical advantages for it in terms of it supplying an adequate amount of essential fatty acids with the soy, a rapid metabolism because of these medium-chain triglycerides and the fish oil for their anti-inflammatory effect, allegedly, and olive oil. We'll see if we ever see those in our lifetime. So fish oil emulsions were first used actually a number of years back in some studies in pigs where they showed, in fact, that it could enhance bile flow. And then some clever people from Harvard decided that maybe this was something that could be used in infants who had parenteral nutrition-associated liver disease. And this is actually just the most recent article using fish oil emulsions. Now, there have been no prospective randomized double-blind trials that have been published. There's one, I think, that the Harvard study, I think, has just been completed. So we're waiting that to see what the real answer is. But at least from retrospective studies, if you take children who have parenteral nutrition-associated cholestasis and then switch them over to fish oil, in this case, these kids had been on the emulsions for about 91 days on the soy. After about 18 weeks, their bilirubins fell from 5.4 to 0.2 when they were switched to the fish oil emulsion. And other parameters also improved. And another thing that happened was their C-reactive proteins also fell, suggesting, in fact, that these solutions may be exerting their benefit through an anti-inflammatory effect. Again, we need to see the prospective studies to know if this is really true, or if it's true, how it's happening. But just because the bilirubin falls doesn't mean that the liver disease goes away. And this is a report from out of Denver recently, where they reported 2 infants who had parenteral nutrition-associated cholestasis. And the cholestasis got better, but the kids actually had liver biopsies, and they showed that the liver biopsies didn't get better. In fact, in one case, it actually showed progression. So just because the bilirubin's getting better doesn't necessarily mean that these fish oil emulsions make the liver disease get better. So a lot more work needs to be done on these. Suggested doses of lipids, starting doses in neonates, infants, children, basically 1 gram per kilo per day, adolescents a little bit less. And theoretically, the maximum dose, as you see here, is 3, 2, and 1. But in reality, one of the concerns that's been about the soy emulsion is maybe it's not actually the soy emulsion, it might actually be the dose of lipid. And this is just 2 of the most recent reports. The first is from Diamond, reported 152 postoperative infants, and they looked at predictors for the development of direct bilirubins, 5.9 milligrams per deciliter a year later. And what they found were the significant factors that would predict that were how many days they had a lot of protein intake. So again, you can overdo it. And there are other data to also suggest that too much protein intake can also enhance the risk of cholestasis. And lipids, greater than 2.5 milligrams per kilogram per day. As we'll talk about later, sepsis is a big risk factor for this. And then a recent paper published first here in current organ transplant, but actually just came out in Journal of Pediatrics from Dan Teitelbaum in Michigan, showed that when they reduced the rate of lipid, when the bilirubin was increased, compared to a historical cohort, those patients who had, all they did was just reduce the lipid intake, their cholestasis seemed to improve. So the big debate now is whether or not it's all fish oil by itself, or it's the fact that in these studies that have used fish oil, in all those studies, they've reduced the dose of lipid down to 1 gram per kilogram per day. Calcium and phosphorus are very important when it comes to parenteral nutrition because parenteral nutrition does not supply enough calcium and phosphorus, particularly for preterm infants. So the longer an infant stays on, or particularly a preterm infant stays on parenteral nutrition, the more calcium and phosphorus depleted they become. And the problem is that there are limitations to how much calcium and phosphorus you can give in parenteral nutrition because when they get together, they precipitate. So one of the tricks that we use to try to increase the amount that you can put into TPN solution is by lowering the pH. And you can do that by either using amino acids that have a low pH to begin with, which is one of the advantages of trophamine, but there are others that also have low pHs, and adding cysteine hydrochloride, cysteine being a semi-essential amino acid, but it also helps lower the pH so you can get more calcium and phosphorus into the solution. You heard about trace elements in the diet. You got to have them in TPN as well. And again, this is just in your syllabus. So, and talk about designing a TPN regimen. I sort of alluded to some of this a little bit earlier. You want to estimate the energy requirements, and that's going to be based on the age of the patient, of course, the disease state, the severity of illness, their activity level, and need for catch-up growth. If you have a healthy kid who is otherwise healthy, again, let's say a Crohn's kid who comes in who's actually well-nourished, but comes in with a bowel obstruction, and then you calculate their energy requirements, well, you're not going to calculate that, let's say, for a 15-year-old who might, let's say, need 2,200 calories because they're not running around with their friends on the weekend, right? They're lying in bed. So their energy requirements are going to be much less. And if you give them the RDA or the estimated, that's right, then you're actually going to be overfeeding them. On the other hand, if you have somebody who's undernourished and you give them the RDA, the usual requirement, you're going to be underfeeding them. So you really need to look at the patient. We always say that, but yet again, when you walk in, you find a lot of times that doesn't happen. You need to calculate the fluid needs. And the bottom line is, when you give parenteral nutrition, you're always going to meet fluid requirements. So I think of it more the other way around. Don't calculate fluid requirements, think that's what the patient needs in terms of fluid requirements, and then you're done with the TPN, because you're always going to be undershooting. As I said, think about the protein requirements separately from the energy requirements. This is somebody who has some enteric protein loss. All right, the protein requirements are going to be increased. Are they hypoalbuminemic because their protein intake has actually been inadequate? They're going to need more protein, and so you use the higher end of those recommended intakes. It's important to obtain baseline laboratory values because, again, these things are going to change once you put somebody on parenteral nutrition. You heard about refeeding syndrome. Thank you very much. It's hell getting old. Refeeding syndrome. And refeeding syndrome, to my mind, is actually an iatrogenic disease. Nobody should get refeeding syndrome because if you think somebody's at risk, then you should be supplementing them with increased amounts of phosphorus at least, and then watching the laboratory values as well. We talked about starting with a lower glucose solution, again, just to prevent hyperglycemia, and then starting with a lower lipid intake. And then the question is whether even you should stick with that lower lipid intake, as I was alluding to earlier. It's important to check your triglyceride level, and sometimes it's important to check that even before you start. If you have a patient that's on steroids, or a patient that's in the ICU, a patient who's stressed somehow, their baseline triglyceride levels are going to be elevated. It's very likely their triglyceride level will be 200 or 225. And so if you don't check a baseline, you start them on lipid, and then 4 hours later you check your triglyceride level like you should. It comes back 200 and you go, oh man, too high, better turn off the lipids or stop the lipids. When in fact, that's where they were to begin with. So think about, again, what your patient's status is before you start, and you might want to check a triglyceride first. Generally, the recommendation is check it 4 hours after you start, and then in with any increase in rate. And then advance the regimen to where you want it to be. And the other point about this is that it should not take a week for this to happen. Right? Basically, somebody should be on adequate calories with parenteral nutrition within 2 to 3 days. Okay? It doesn't need to be any slower than that. And there have been other studies that even showing that could be the case in preterm babies. And preterm babies used to drag on for eons before they finally got adequate calories. And even in the smallest preterm babies, they can be on adequate calories within a couple days, and should be. If you're going to use it, you should use it to where it helps the patient. So energy requirements. You heard a little bit about this already. There are these formulas that you can use to calculate energy requirements. Obviously, in the first year of life, you talk about calories per kilogram. In older kids, you just talk about total kilocalories per day. Ideally, measuring energy expenditure is particularly helpful in ICU patients, again, because you really don't know what's going on with them. And then was not on the table before is that for infants, somewhere around 80 to 100 calories to 110 calories per kilo per day. Again, you see this big range. There are breastfed infants who do great on 80 calories per kilo, others that won't grow on that amount. This is somebody gave me this. You sent me this, but somebody else sent you this. This is actually a neat thing. It's a TPN calculator where you just put in the patient's weight and so forth. Did this come from somebody here? No, didn't. Okay, anyway. Here's the web address. Anyway, it's a great way to quickly calculate all the requirements for somebody on parenteral nutrition. The only thing that it doesn't do is doesn't account for catch-up calorie needs. So it provides maintenance requirements, but not catch-up requirements. But it's pretty cool. Other components of parenteral nutrition, the minerals and amino acid balance. So again, it's important, I think, to get baseline values here, and then also think of other sources of electrolytes and minerals. And this usually comes in the form of primarily sodium, because patients may be getting other infusions that contain sodium. They may be getting other infusions that contain glucose too, so they may be getting other sources of calories. And mostly this is an issue for patients who might be in the ICU, have some degree of liver problems or renal problems, where you want to watch more carefully their actual intake of these nutrients. Check laboratory values within 24 hours of starting parenteral nutrition and adjust accordingly. On the other hand, I think, at least at our place, many people basically drain the blood volume of patients checking labs on parenteral nutrition. The point being that after a day or two, if you haven't changed the parenteral nutrition solution and the labs are stable, the electrolytes are stable, there's no reason to keep checking those every day. The problem, particularly in the electronic medical records, is you put an order in, you hit a button, and it's an order that just keeps repeating and repeating. And then on rounds, everybody's got something to say. Well, the electrolytes today were so-and-so and so-and-so. And in fact, they've been stable for the last 3 weeks. So I think it's important to use your brain for a second and look at the lab values and decide, do I really need to keep getting these? And if I don't, then when should I repeat them again? And we'll talk about it in a second. The other thing is when you need to treat acid-base abnormalities, never, ever add bicarbonate to TPN solution. That's because it will cause calcium and phosphorus to instantly precipitate. And so the patient will lose their central line or lose a peripheral line. And so if you need to add bicarbonate, you have to add the bicarbonate precursor, which is acetate, which is then metabolized in the liver. And also be careful of the high sodium load that can come also with sodium acetate, because that usually comes either as sodium acetate, can also come as potassium acetate. So it's another way that you can juggle electrolytes. So a couple of points about inflammatory bowel disease. Forgive me if this was talked about last night. It was, yeah? A little bit. Okay. So anyway, somebody mentioned zinc to Maria. This is one case where these patients tend to be or have a risk for zinc deficiency if they have an ostomy or diarrhea. Iron deficiency, they tend to be vitamin D deficiency, and I guess you guys talked about that. So more importantly, short bowel syndrome, at least for today, these patients obviously have a lot of enteral fluid loss, and so you need to keep up with that, and oftentimes you can incorporate that enteral loss actually into their daily fluid requirement in the TPN. Zinc is an important product to think about when it comes to short bowel, again, because they tend to have a fair amount of enteral loss. Zinc tends to be lost in the GI tract, so they tend to be at risk for zinc deficiency. A lot of times we'll just empirically put these patients on twice the quote-unquote normal zinc requirement. They tend to be at risk for acidosis, and so again, we oftentimes will add acetate if need be to their TPN. On the other hand, you can make a patient acidotic, particularly short bowel patient, by trying to feed them too much and actually inducing diarrhea by giving them too much carbohydrate that then gets fermented, turns into fatty acids, that gets absorbed and makes them acidotic, along with hydrogen iron. So you have to think about that too, that you might be making them acidotic because of the feeding, and you might be chasing your tail by adding the acetate. But if you are feeding them appropriately and they still are acidotic, then use acetate. Sodium is actually important in short bowel patients because, again, sodium is lost, and patients will not grow if they're not getting adequate amounts of sodium. And just last time I was on service, actually I just was on service, but when I was in service before, we had a patient who had long-term ostomy, and the patient really wasn't growing that great. And the other point was that the patient's sodium was sort of on the lowish end, and I told the team, I bet you if we get a urine sodium, it's going to be incredibly low. And they said, well, no, why? This serum sodium's normal, everything seems okay. I said, trust me, just check it. And the urine sodium was like 1, right? So that's a patient over time who would continue to even do worse in terms of their growth because they're chronically hyponatremic. So again, that's another thing to think about in patients who have any kind of GI loss. Actually, the same thing is true here, particularly even in patients who have NG tubes can have low zinc because of the NG drainage. Iron loss in short bowel patients, sometimes this is tricky to figure out whether it's due to the anemia of chronic disease or due to iron loss or iron deficiency. So cycling TPN. So cycling TPN means administering TPN over less than 24 hours. And usually the average is about 10 to 12 hours in an older kid. In a baby, it might be more like 14 to 16 hours. The prerequisites are they have to be on a stable regimen of TPN. You don't want to have to be making lots of changes. They need to handle their volume of fluid, so if they're getting all the requirements from parenteral nutrition, they need to be able to handle all that fluid within a much shorter period of time. And as I mentioned, the smaller the infant, the shorter the cycle may be. The putative benefits are decreased hepatic injury, and I'll talk about that in a second. And of course, it makes for a much better life, right? So really, unless there's some extreme reason why they shouldn't be, all patients, at least on home parenteral nutrition, should be on cyclic TPN. And there's even an argument, as we'll see, based on the liver side of things, that maybe we should be doing the same thing in the hospital as well. When we do that, you need to wean the parenteral nutrition rate for the last hour, decreasing it by 50%. In some patients, you might want to decrease it an hour before you stop by 50%, wait another 30 minutes and decrease it again by 50%. And doing the same thing when you start off the solution, again, so that patients don't become hyperglycemic. And then you want to stop the solution and then check the glucose at least on a couple days after you stop it to make sure they're not hypoglycemic. Again, you don't need to do this every single day if the patient's been stable. And particularly if they're on enteral feeds. This is mostly for patients who are on very little enteral feed. There are actually 2 studies to suggest that you can improve or prevent, well, let's say improve, liver disease by cycling patients. And in fact, I have to say I was sort of one of the naysayers. Many years ago, there were a lot of rat studies of parental nutrition and cycling parental nutrition and showing some metabolic advantages and that kind of stuff. But there was really no human data, and I always wondered whether or not it really made a difference. And then the study by Huang came out about 10 years ago or so. And what they did was they took adults who were on parental nutrition, continuous parental nutrition, and on some of them they turned them to cyclic TPN. And the others, they kept on continuous TPN. And what they found was, except for those patients who had the highest direct bilirubins, all the other patients actually had a decline in their bilirubins by doing nothing other than putting them on cyclic TPN. So there's another study by Jensen published more recently, which was a retrospective review of 107 infants with gastroschisis, and that's shown on this slide. So here are the kids who were maintained on continuous parental nutrition. Here are the kids on the cyclic parental nutrition, and here's the cumulative incidence of direct bilirubins. So I think at least retrospectively, there's some pretty strong data to say that cycling TPN is really pretty important, at least when it comes to injury to the liver associated with parental nutrition. So monitoring complications. You need to really watch what you're putting into the parental nutrition to be sure that you're not doing anything wrong on our side. It's a frog. But it's extra protein. Okay. So parental nutrition monitoring, again, as a baseline, you should get all the chemistries. How often you should get them, really? Well, then when you change things in the parental nutrition, you should think about doing that. Certainly for the lipids, you should do that. Electrolytes, you should do that. And then what happens after that? Really, again, it depends on the patient. This is a rough guideline. It's not written in stone, weekly until stable. And patients who go home on parental nutrition, some of them may not get their labs checked but every 2 weeks, some not every 3 weeks, sometimes not even, but every month when they've been on for a long time and really very stable. So again, that totally has to be individualized. Complications of parental nutrition. Has anybody ever not seen a complication of parental nutrition? All right, okay. So of course, infections, big thing, mechanical things, or metabolic things. I would submit that all these metabolic things are our fault, except for maybe parental nutrition-associated liver disease, and even that to a certain degree. So all these things we can prevent. Electrolyte abnormalities, overfeeding, underfeeding, refeeding syndrome. Some patients may have an allergy to some of the components in the parental nutrition, like the vitamins. And then rarely patients who are on very, very long-term TPN actually can get a nephropathy. But most of the complications we can prevent. TPN liver disease, just to cover this quickly, well-known complication, probably happens in about 40-60% of neonates and maybe 15% of children, and happens in adults too. Although in older children and adults, they usually get more steatosis kind of picture and fibrotic kind of picture rather than cholestasis. The pathogenesis could be 3 tox all by itself. Just to say that it's multifactorial. The longer you're on, the worse chance you're going to get, or the bigger chance you're going to get it. If you're premature, then you're really in big trouble. Sepsis, infection, even bacteremia is a major, major contributor to it, and so is surgery. But also, as I mentioned earlier, some of the things that we do also potentially could ameliorate liver disease. So the treatment, we talked about using the fish oil emulsions. You can get those on a compassionate basis, hooking up to some of the centers like Boston, like our place in Houston, a bunch of other, Cincinnati, I think does too, for patients who really have no other recourse. As we talked about before, make sure you give as much enteral as you can. I think cycling TPN is probably underutilized. Some of these patients have bacterial overgrowth. Not everybody, but if they do, again, that's a great risk factor. We talked about reducing the lipids. I think maybe that's something we should be doing a lot more than we are. We talked about fish oil. And then ursodeoxycholic acid has been used in parental nutrition-associated liver disease, but it's not all that great. But it makes us feel better. Okay, so when patients really get bad liver disease on parental nutrition, you have to think about referring them if you're not already at a center that can do transplants or do take care of really these kids with really significant liver disease. And this is sort of a rough guideline of what you should think about. So in a patient who's been on for more than 3 months and has greater than one or more of the following, these are the kind of kids that are going to wind up with parenteral nutrition-associated liver disease likely and should be referred. As I mentioned a few slides ago, infection is really the number one thing, probably one of the number one things that really contributes to cholestasis. That can either be in the form of small bacterial overgrowth. There have been studies to show that patients with short bowel syndrome particularly, or on long-term TPN without enteral feeds or little enteral feeds, have actually ongoing inflammation, which probably contributes to the liver disease. And all these contribute to the cholestasis. This is interesting a case report to suggest that how important just the inflammation might be. This was an adult lady with Crohn's disease who was not doing well with her Crohn's disease, had a fistula. And you can see, this is her bilirubin, she was getting more and more cholestatic. So because she was doing so poorly and her bilirubin was rising, they tried reducing her lipid amount. And she wasn't getting that much lipid to begin with, but they cut it in half. And when they did that, there wasn't really much change in her bilirubin. But then, because of her Crohn's, they decided to put her on infliximab. And after they put her on infliximab, she had this dramatic decline in her bilirubin, even though her lipid intake they were still giving her lipids and it hadn't decreased the intake any further. So it suggests, in fact, that this inflammatory component that's going on in patients may really play a big role in cholestasis. Infectious complications. How many of you have not taken care of a patient who's been septic on TPN? Okay, that's easy, right? So patients oftentimes will have colonization of their catheters. Doesn't mean they're necessarily infected, but so many of these patients do get infected. Oftentimes it's from the gut, particularly for short bowel patients. And many times it will come from these fibrin sleeves. Essentially all central catheters have these fibrin sleeves on the outside that serve as a nidus for bacterial growth. A couple of things that you can do, obviously, to help reduce the risk. Multi-lumen catheters are a particular risk. I think Mark will talk about that. Doing all the things you're supposed to do, but even then, patients will get septic. There have been no prospective trials, to my knowledge, of using ethanol locks in kids, but at least from people's experience, they seem to be beneficial in some patients, reducing the risk of these patients coming back with infection. The other thing to think about is many patients, as you know, wind up getting fungal infections, and then some people are now, when these kids come in with repeated infections, will prophylactically put them on antifungals as well as antibiotics. A few words about home parenteral nutrition. In the U.S., it accounts for about 14% of patients are pediatric patients. They certainly should go home if they can, as long as everything's stable, meaning not only their TPN, but also obviously the family situation as well. And this is a good source for patients on home TPN. The Oli Foundation is a foundation for people who are home on TPN. 5-year prospective study showed that the primary cause of death on home TPN was really related to the underlying disease if the TPN regimen if they were home for less than 2 years, basically. For those who were on for greater than 2 years, it tended to be TPN related. But that said, over this 5 years, of the 90% kids who were not transplant eligible were still alive at 5 years. 90% who were eligible for transplant but didn't get transplanted were still alive. And 75% of those actually transplanted were still alive. I gave a talk a number of years back at a symposium that was held by transplant surgeons, intestinal transplant surgeons, and they wanted me to talk about TPN, and I didn't go over very well. And the reason I didn't go over very well was because I showed that actually patients on parenteral nutrition did very well for a long time, and they didn't want to hear that. But it's true, and particularly if you take care of them well. So economically, it's much cheaper to have a patient home on parenteral nutrition than it is in the hospital. That's sort of a no-brainer. And as I alluded to earlier, a lot of these patients, particularly short bowel patients, don't grow very well. And if they don't grow very well, it's our fault. Because again, they should be able to grow if we pay attention to their intake and are very conscientious about making sure that they get the appropriate intake. So in summary, parenteral nutrition can be life-saving, but if we're not careful, it can also be life-taking. I think most of the problems are iatrogenic, either because we use it when we shouldn't, or when we use it, we're not using it carefully. That's related to inattention to detail. But unfortunately, still, a few patients just have bad luck and don't do well.